hope we can collaborating with the Indonesians associate hip and knee surgery. Hope we can collaborating with the Indonesians associate hip and knee surgery. Collaborating with the Indonesians associate hip and knee surgery.
Our vision is to transform patient care through professional education to ensure that more patients live longer and healthier life. We are Meril Academy, and we believe knowledge is future.
Audio Jungle. Audio Jungle.
An institution dedicated to make life healthy again. We believe in creating a sustainable ecosystem for the world, where knowledge is everything at Meril Academy.
Audio Jungle.
We wish to empower doctors and paramedical staff with in-depth and explicit knowledge and skill upgradation. Our collaborative learning model, well-structured and specially designed programs make sure that innovation happens daily at Meril Academy.
I'm really impressed. This is really top-notch of the educational process. One thing is when you hear something, and second thing is when you come and see and feel, meet all these people.
It's a very great place for education. Lectures with live surgery, like academic in USA and Europe. It's very good for education with detailed tricks in surgery.
Collaborating with the Indonesians associate hip and knee surgery.
People who are pioneer in their respective field from different parts of the world to come under one roof and share knowledge is an excellent approach in carrying this medical education forward.
Academy, structure-wise, infrastructure, arrangement is very good and it's great.
Audio Jungle.
feel very proud that in India we have such a beautiful center, which is no less, maybe more than any international center.
It's very far away from my beyond.
The teaching is excellent, and the organization of this course is quite good.
And modern facility for training and education.
I can recommend to my colleagues to come here and to get
and get to, the sky's the limit.
Our vision is to transform patient care through professional education to ensure that more patients live longer and healthier life. We are Meril Academy, and we believe knowledge is future.
Audio Jungle. Audio Jungle.
An institution dedicated to make life healthy again. We believe in creating a sustainable ecosystem for the world, where knowledge is everything at Meril Academy.
Audio Jungle.
We wish to empower doctors and paramedical staff with in-depth and explicit knowledge and skill upgradation. Our collaborative learning model, well-structured and specially designed programs make sure that innovation happens daily at Meril Academy.
Audio Jungle.
This is I'm really impressed. This is really top-notch of the educational process. One thing is when you hear something, and second thing is when you come and see and feel and meet all these people.
It's a very great place for education. Lectures with live surgery, like academic in USA and Europe. It's very good for education with detailed tricks in surgery.
Audio Jungle.
I hope we can collaborating with the Indonesians associate hip and knee surgery.
People who are pioneer in their respective field from different parts of the world to come under one roof and share knowledge is an excellent approach in carrying this medical education forward.
Academy, structure-wise, infrastructure, arrangement is very good and it's great.
Audio Jungle. Audio Jungle.
I feel very proud that in India we have such a beautiful center, which is no less, maybe more than any international center.
It's very far away from my beyond.
The teaching is excellent, and the organization of this course is quite good.
And modern facility for training and education.
I can recommend to my colleagues to come here and to
get to, the sky's the limit.
Our vision is to transform patient care through professional education to ensure that more patients live longer and healthier life. We are Meril Academy, and we believe knowledge is future.
Audio Jungle. Audio Jungle.
An institution dedicated to make life healthy again. We believe in creating a sustainable ecosystem for the world, where knowledge is everything at Meril Academy.
Audio Jungle.
We wish to empower doctors and paramedical staff with in-depth and explicit knowledge and skill upgradation. Our collaborative learning model, well-structured and specially designed programs make sure that innovation happens daily at Meril Academy.
Audio Jungle.
This is I'm really impressed. This is really top-notch of the educational process. One thing is when you hear something, and second thing is when you come and see and feel and meet all these people.
It's a very great place for education. Lectures with live surgery, like academic in USA and Europe. It's very good for education with different tricks in surgery.
Audio Jungle.
I hope we can collaborating with the Indonesians associate hip and knee surgery.
People who are pioneer in their respective field from different parts of the world to come under one roof and share knowledge is an excellent approach in carrying this medical education forward.
Academy, structure-wise, infrastructure, arrangement is very good and it's great.
Audio Jungle.
I feel very proud that in India we have such a beautiful center, which is no less, maybe more than any international center.
It's very far away from my beyond.
The teaching is excellent, and the organization of this course is quite good.
And modern facility for training and education.
I can recommend to my colleagues to come here and to get it.
And get to, the sky's the limit.
Audio Jungle. Audio Jungle. Audio Jungle.
Our vision is to transform patient care through professional education to ensure that more patients live longer and healthier life. We are Meril Academy, and we believe knowledge is future.
Audio Jungle. Audio Jungle.
An institution dedicated to make life healthy again. We believe in creating a sustainable ecosystem for the world, where knowledge is everything at Meril Academy.
Audio Jungle.
We wish to empower doctors and paramedical staff with in-depth and explicit knowledge and skill upgradation. Our collaborative learning model, well-structured and specially designed programs make sure that innovation happens daily at Meril Academy.
Audio Jungle.
This is I'm really impressed. This is really top-notch of the educational process. One thing is when you hear something, and second thing is when you come and see and feel and meet all these people.
It's a very great place for education. Lectures with
writing with Indonesians associate hip and knee surgery.
People who are pioneer in their respective field from different parts of the world to come under one roof and share knowledge is an excellent approach in carrying this medical education forward.
Academy, structure-wise, infrastructure, arrangement is very good and it's great.
Audio Jungle.
I feel very proud that in India we have such a beautiful center, which is no less, maybe more than any.
Hello. Good morning, sir.
Good morning. Good morning.
So we'll be starting in 5 minutes.
Good morning, Dr. Desai. Hi.
Good morning, Dr. Dar. Great to see you again. And good morning to the Meril team.
Good morning. Very good morning, sir.
Can we check before we go live the presentation? You can see this?
Sure, sir.
It's written only host can share in this meeting. You have to share.
Yes, sir. So there is a share screen.
Yeah, but you have to allow that share. It is saying only host.
The host has to give permission.
Yes, yes.
Yes, sir. The permission is given.
Okay. Can you see?
Yeah.
Yes, sir. Yes, we can see, sir.
Okay. Thank you.
So, Avinash, I think the format will be about 20 minutes of presentation by myself and Dr. Dar.
Right, sir.
And then 10-15 minutes for question answers. Is that correct?
Yes, sir. This is correct, sir.
Who will receive the questions?
Sir, questions will be received over chat window and I shall receive the question and pass on to you.
On WhatsApp?
On WhatsApp also we are available. The questions we are getting on YouTube also, and it's live streaming on YouTube and over chat window also.
Yeah, but you will pass it on to me and Dr. Dhar on WhatsApp.
Right, sir. On WhatsApp.
Okay.
Dr. Desai will be starting the first presentation for me.
Yes, sir. Shall we start, sir? I'll just give a brief, sir.
Yeah.
So a very good morning to all of you, especially to our eminent faculties and more than 150 delegates who have registered on behalf of Meril family. My name is Avinash and I shall be your facilitator for this webinar. And it gives me immense pleasure to welcome you all on this fine morning for this program. This is really heartwarming to see that all are connected on this platform for this academic session. A special welcome to Dr. Sanjay Desai, who is shoulder and knee surgeon here in Mumbai, and who will speak on the topic proximal humerus fractures need to innovate. Dr. Desai is a super specialist who is trusted by celebrities over here in Mumbai. He is man who is responsible for revolution in shoulder surgery in the subcontinent. He is founder member and past president of Shoulder Society of India. He is past president of Indian Orthopedic Society and current president of Asian Shoulder Association. He has received Young Achievers Award in 2002, conferred by Indian American Society. Dr. Desai has received Giant International Award in 2016 for his contribution in the field of medicine. Moreover, he is recipient of the Most Inspiring Doctor Award by Economic Times in 2018. Above all, Dr. Desai is recipient of the prestigious Dr. B.C. Roy Award in 2019, and this award is considered as the highest award in the medical sciences given by President of India. Now I welcome Dr. Sanjay Dhar, who is consultant orthopedic surgeon here in Mumbai, who will speak on the topic periarticular fractures of distal radius. He is postgraduate teacher of orthopedics in Mumbai University and Maharashtra University of Health Sciences, Nashik. He has contributed as faculty and chief coordinator in many academic events in Malaysia, Dhaka, Bangladesh, Laos, Nigeria. He served as honorary secretary in Bombay Orthopedic Society from 2016 to 2018. He was also organizing secretary in VIROC 2003 Mumbai. He is member of executive committee in Bombay Orthopedic Society from 2000 to 2003. His important publications are Diagnostic Significance of Magnetic Resonance Imaging in Hip Pain in Children, published in J. Orthop, Secondary Internal Fixation in Open Comminuted Fractures of Femur, Is This Corrective Alternative? Classification of Metaphysical Changes with Magnetic Resonance Imaging in Leg Cleft Perth Disease, and Failed Back Syndrome, textbook of Orthop and Trauma. Our both eminent faculties have more than 30 plus years of experience. So it will be a great academic feast on this morning of Sunday. Sir, over to you, Sanjay, sir. Sanjay Desai, sir.
Yeah. At the outset, I must thank Meril team for organizing this webinar. And it's an honor and a pleasure to share the platform with my good friend and colleague, Dr. Sanjay Dhar. And without wasting much time, may I go ahead with my presentation on proximal humerus fractures. Can you see my screen, Avinash?
Yes, sir, I can see, sir.
Now, proximal humerus fractures continue to challenge orthopedic surgeons across the world, especially the displaced four-part fractures of proximal humerus. Now, to begin with, it's a great relief to know that 80% of fractures of the proximal end of humerus are minimally displaced, and they do very well with simple non-operative or conservative treatment. So here is an example to make my point. This is a mother of a gastroenterologist colleague of mine. She's 64 years old, and I'm not sure whether to call this a 4-part, 5-part, or a 40-part fracture, and I really don't care. What matters to me is that this is minimally displaced X-part fracture And if it is minimally displaced, as majority or 80% of proximal humerus fractures are, they will do well with simple conservative treatment. And this is 6 months X-ray and clinical video. And you can see that she has almost 100% shoulder function. So my young colleagues in particular, bear in mind that conservative treatment can be very effective and useful in a large majority of proximal humerus fractures. But the real challenge is the remaining 15 to 20%, which are displaced fractures. And in those, it's the 4-part fractures and 4-part fracture dislocation, which are a real challenge even today. And it's extremely difficult to get a good functional shoulder with consistency in this category of fractures. And we all know that there are various modalities of treatment available for these displaced fractures. And let me remind you that from now on, my talk is going to be for these 15 to 20% of displaced proximal humerus fractures, in particular the 4-part. So coming back to the various modalities, you can see here, you can do the most popular is the locking plate. Then you have what I call the concept of control aggression, where you use only rotator cuff anchors and high tensile sutures. You have percutaneous wiring. You have hemiarthroplasty. You have now the reverse shoulder arthroplasty as a primary form of treatment for some 4-part fractures in the elderly. And then you have nailing as well. And to this, I'm going to add what my talk is about, a unique implant, which is an intramedullary device. And it goes by the name of just Unic. And I will give you the details in the slides to follow. Before I talk about this relatively new implant, I think we have to admit and accept that there is a problem with the current methods of fixation of displaced proximal humerus fractures. Let me show you a few examples to convince you that we have to accept that there is a problem. So this is a gynecologist, 73 years old, looked like a simple 2-part fracture. Somebody fixed it with a locking plate. And this is what has happened in a few months' time. And this kind of a picture where the head has fallen into varus and the screws are jutting out and damaging the glenoid surface is not an unusual experience, and we all have seen it. Example number 2, a 4-part fracture, and you can see that the tuberosities are flying. I don't believe that this surgeon, whoever did it, was any inferior surgeon. I'm sure he is a skilled surgeon and an experienced surgeon. But the point is that the tuberosities, even if they are secured, can be very difficult to maintain in that position until they heal. That is the way the biomechanics of the proximal humerus works. Example number 3, a cowboy-like fixation. I have no comments to make. This is a day 1 failure, some tension band wire and a screw, which is now proud. And after implant removal, it's a disaster. One more example done very recently in Mumbai, 2019 June. 62-year-old male, a displaced 3 or probably 4-part fracture. Again, rush nails with tension band wiring. It's an unconventional, probably illogical method of fixation without understanding the biomechanics of the proximal humerus. It's a day 1 failure. And then I can show you many more failures of the current available methods of fixation. Example 5, example 6, example 7, 8, 9, and believe me, I could go on whole day giving you examples of failed methods of fixation as they exist today. Now let's look at the infamous or famous PROFER trial, published in 2015. Those who are not familiar, it was a multi-center trial in the United Kingdom. And what they concluded is that whether you operate or you don't operate these proximal humerus fractures, the results are the same, which means they were implying that there is no point in operating these fractures, which shook the orthopedic world, because it becomes difficult then to advise surgery to any proximal humerus fractures. Now, according to me, my interpretation is that this study is flawed. And let me give you the reason. They presented 250 cases. And look at the breakup of these 250 cases. 18 one-part fracture, 128 two-part fracture, and 104 3 or 4-part fracture. And they clubbed all of these together. So it is, as you can see, it is extremely difficult to interpret this study if you are going to put all of these into one basket and then say that the result do not differ whether you conserve or operate. So it is very, very difficult to interpret this result accurately. My interpretation of this study is that they came out with this conclusion that it doesn't matter whether you operate or you don't operate, the result is same. It reflects that it does not reflect that the results of conservative treatment are very good. What it reflects is that the results of operative treatment are so poor and unpredictable that even if it did not operate, it will remain the same. So it speaks about the inconsistent results of the current methods of fixation, particularly in this difficult subgroup of 4-part displaced fractures of proximal humerus. So why is it so difficult to get a consistently good result in this particular group? Multiple reasons, as you can see here, that often the head component is just a shell, like a coconut shell, with very poor quality of bone and therefore hard to secure with screws, even if they are locking screws. It is difficult to fix and maintain the reduction of the tuberosities. And eventually, many of these will either go into malunion, non-union, the tuberosity can undergo resorption, or the tuberosities might be flying and leading to a non-functional or a poorly functional shoulder. And a large number of these can also undergo avascular necrosis. So therefore, all the current methods of osteosynthesis eventually lead to a poor functional shoulder. When the world experienced this problem, they started doing hemiarthroplasty for these displaced 4-part fractures. But the hemiarthroplasty also had a problem, and it was the same problem, the tuberosities. It was very, very difficult to get the tuberosities to heal consistently in majority of these cases. So half of them would unite, but as large as 50% would go into a non-union of the tuberosities, leading to a cuff deficient hemiarthroplasty, which is even a worse situation than a conservatively treated proximal humerus fracture. So here are 3 examples of hemiarthroplasty, and all of them failed because of tuberosity not uniting. Pascal Beaulieu, who has a very large experience of these proximal humerus fractures, in his study said that almost 50% of these tuberosities will either migrate, go into non-union or malunion. And hence, at least in that part of the world, they have stopped doing hemiarthroplasty for 4-part fractures of proximal humerus because of inconsistent result. So internal fixation with locking plate, high failure rate. Hemiarthroplasty, high failure rate. Why is this? And I think the reason is that we have failed to understand the biomechanics of the proximal humerus. And there is a fundamental flaw in our understanding and therefore the technique. And hence I think very strongly that we need to now think out of the box and move away from the conventional methods of fixation and innovate something new, such as this intramedullary device. As you can see, it has three components. It's got a staple, which is a circular staple with a central more staple hole. Then you have the stem, and the stem has a outer shell, and the stem can be increased or decreased in height within the outer shell and locked with that screw, as you can see in this picture. This is the bull bouquet, which is a staple in French language, concept developed by Professor Duzonian from Paris. So let me show you some examples of this very unique intramedullary device. So here is an example of a road traffic accident, a relatively young patient of 45 years old, dominant arm. He had a 4-part, very badly comminuted displaced fracture along with a vascular injury, as you can see in that lower right side picture. And therefore, I had to call in a vascular surgeon who put a graft in the axillary artery. And this is the Just Unic device. And look at this result. Be honest and ask yourself, would it have been possible to produce this kind of a functional shoulder with any other currently available methods of fixation? Very, very difficult. Example number 2, a 68-year-old displaced fracture of proximal humerus, 3 or probably 4-part. Again, a Just Unic done. And this is the 8-month X-ray with very good position and union of the fracture. Example number 3, a badly displaced fracture of proximal humerus in a 52-year-old female. This is 8 months post-op. It is united very well in an anatomic position, and the constant score is 96. Example number 4, this is more of a head split. Now, this head split is not an ideal indication for Just Unic, but I was so happy with this fixation device that I went ahead and put the staple with 1 or 2 prongs holding that split head. And you'll be surprised that even the head united and there was no avascular necrosis. This patient is now more than 2 years post-op. This is 10-month post-op follow-up showing union. The head is vascular and he has a constant score of 90. So excellent shoulder function. Imagine all these. If I would have plated, I'm not sure how many of this would have failed. This earlier example I showed you of rushed nails with tension band wiring. I revised it, put a Just Unic implant, and again it is united with excellent shoulder function. Example number 6. This is a failure which I want to share with you. The 64-year-old male, right-handed, dominant hand, a displaced fracture of the proximal humerus, and there is a butterfly fragment as well. And I had committed myself to the superior or the Mackenzie approach, which is what is my first choice. And therefore, it was very difficult for me to have access to that butterfly fragment, and I could not fix it. So I left it as it is. And this led to an unstable stem, and this failed in 2 months' time. So my advice to you from this experience is that if you have the fracture extending into the proximal shaft of the humerus, then either you don't use this implant, or if you still want to use the implant, please use the deltopectoral approach so that you can extend your incision and do some form of fixation of that butterfly fragment so that your stem is relatively stable. Of course, I revised this to a reverse shoulder arthroplasty. He is more than 3 years post revision surgery, doing reasonably well. This experience of mine has been already accepted for publication. This is the DOI number. Those of you who want to note it, it is to be published sometime in the next month or 2 in the Journal of Shoulder and Elbow Surgery. 30 cases, average follow-up a little more than 2 years. Union was achieved in 93%, and the average American shoulder and elbow constant score are in somewhere in mid-70s. So it is possible to get consistently acceptable results with this device. We had 2 cases of avascular necrosis. One case did not want any further surgery, And the reason is because even though he had AVN, his tuberosities had united very well. So his cuff was fine. And I have seen on several occasions that if the tuberosities unite and the cuff is functional, then AVN is tolerated very well, unlike the femur. One patient had pain and underwent a hemiarthroplasty. So when would you be not using or be very careful with this implant? Like I said earlier, you should know in which cases you need to do this. I'm not saying that you do it in each and every case, but particularly displaced 3 and 4 part fractures, it is my first choice. Be careful when the fracture is extending into the proximal shaft. So when would I do a reverse shoulder arthroplasty as my first choice? It is primarily to do with age. All the examples that I showed you were relatively young. They were in either late 40s or 50s or early 60s. In contrast, if you have a patient like this with fracture dislocation and is 72 years old, then I would perhaps opt to do a reverse shoulder arthroplasty as a primary form of treatment. The reason is at 72, I do not want to do an operation which may necessitate a second operation. And therefore, a reverse is my choice in patients who are 70 and above. Barring this, which I stretch the indication for a straight reverse, is a 68-year-old, a little less than 70. But why I did a reverse straight away, not a just unique or not a plate, is because there is a lot of communication and the head is shattered. The articular cartilage is probably into many pieces. So this perhaps is not a good case to reconstruct. You will have a painful stiff shoulder and hence a reverse shoulder replacement, though the patient is a little less than 70. My warning to you, do not take up reverse very lightly and don't start doing reverse in each and every displaced proximal humerus fractures, particularly if the patients are relatively young. Have a look at this. This patient is 70 years old. He's a general surgeon by profession. He had to be operated 4 times because of an unstable reverse. Another example of a reverse done somewhere and is infected. This is 2 years post-op and I have to now revise this. Another example of a 62-year-old reverse done for a proximal humerus fracture and there is disassembly of the construct. So therefore, reverse can be a challenging procedure and one has to be trained and reasonably experienced to undertake reverse. So in conclusion, ladies and gentlemen, displaced 4-part fractures of proximal humerus, particularly in the age group below 70, which means late 40s, 50s, and 60s, my first choice is the just unique. We need to think different and we need to innovate. Thank you very much, Meril, once again. I end my talk with this slide. Thank you.
Thank you so much, Dr. Desai.
Somebody's microphone is on. Can the host close that?
Please mute your...
Yes.
May I request everyone to mute your...
The host can mute everybody.
Right. Thank you very much, Dr. Desai, for your presentation. So now we shall proceed with the presentation of Dr. Dhar, and then there will be question and answer round, sir. Over to you, Dr. Sanjay Dhar.
Yeah. Avinash, may I suggest that the host should mute everybody else?
Yes, sir. Sir, he has already muted, sir.
Can you see my slides?
Very much.
Okay.
I can see.
Okay, thank you. Good morning. First of all, I must thank Meril for allowing me to share my experience in distal radius fractures, and I must thank my colleague, Dr. Sanjay Desai, for a very nice presentation. Just Unic is even close to me now. I have had experience in doing this surgery, and I learned it from Dr. Desai also, although he doesn't know it. Thank you very much, Dr. Desai. We'll have more on that later. Meril, I must tell you that I have been to that campus in Vapi. It is a beautiful campus. I'm sure all of the people who are watching this should visit that place. It's a unique example of Atmanirbharta, manufacturing processes and the whole setup. Hello, can we mute them? Hello.
Yes.
Okay. Just mute. It's very distant. So I'll be talking about distal radius fractures from a complicated injury like proximal shoulder fracture. Distal radius fracture is a simpler injury, although we are in exciting times in treating these fractures because with so much array of implants available now and techniques available, I'm sure this is an exciting fracture to treat because you have so much available. And with better understanding of kinematics, anatomy, and mechanism of injuries, and mechanism of fixations, we are in a better position to treat these fractures. Anatomy, I think most of you know the anatomy. It is based on the distal radius fractures. We are worried about the two facet, the scaphoid fossa, lunate fossa, and the third column, which is called the ulnar column, where you have the TFCC and the ulnar distal end. So it is the restoration of this articular structure and these fossae that is the ultimate aim in the management of distal radius fractures. So the distal radius, the articular surface, is designed to transmit axial load and provide stability. The distal, the carpus, the lunate, and the scaphoid, it acts as a pile driver. Whenever you land on your wrist, the load is the bearing is through the central area of these fossae. And out of that, the lunate fossa bears almost 40% of the weight. And so restoration of this lunate fossa is the sort of a central point in restoring the distal and distal and radius architecture. So good X-rays are important in doing this. In fact, I must agree that better understanding of X-ray techniques has led to better understanding of these fractures. Earlier, we used to have just AP and lateral view. Now we have many other views which have sort of revealed the underlying or many cryptic injuries which probably we used to ignore in while treating these fractures. So a true lateral view is very important. So you need to see that your pisiform is how much it is overlapping the scaphoid. So ideally, it should be on the medial side of the medial 2/3 of the scaphoid, as you can see in the picture. So that will make a lot of difference in understanding. In fact, post-operatively, such X-rays are very important in seeing your fixation and seeing the quality of your fixation. So what is now called as tilted views or the facet views have become sort of a must-do in managing these injuries post-operatively by simply keeping either an autoclaved crib bandage or any small bolster-like thing or a Gamgee roll. You can get a good lateral view, which is a facet view where you can see the full concentricity of the lunate with the lunate fossa of the radius. So that should be sort of matching when you are seeing these X-rays and when you are seeing post-operative views. Before the X-rays, we should also know a few features like what is called as the teardrop of the distal radius. It is the outpouring margin of the lunate fossa, which you can see, which I have marked in the picture here. So that is any deviation in that position or that angle, which normally should be around 70 degrees, that means that your fragment is in dorsal tilt or in more volar tilt. So the restoration of this angle becomes very important post-operatively. It's very simple to draw it. It is the axis of your radius and then the mid-axis of your teardrop in a tilted view. So as these fractures come, I'm talking of intra-articular fractures. So it's very important that you take traction views. I generally prefer to do a reduction in the ER itself, even if it is without anesthesia. You just pull them and give a slab in that position, so that makes the many fragments revealed and many the position of the fragments much more clear. So that gives you a lot of time. You restore the length of the radial column. You get the fragments in little better position, and then you can take either a CT scan or hello, and you can get a better understanding of these fragment positions and intraarticular fragments, because there are few things which you need to understand. That is the lunate fossa, the dorsal rim of the lunate fossa, the volar limb of the lunate fossa, and the scaphoid fossa. These are very important elements in these fracture configuration, and you need to restore these fracture position, these fragments, to get a good restoration of the distal articular surface, and then ultimately a good result. CT scan now is the sort of a cornerstone of preoperative investigation, not only in understanding the fragments, but revealing, as I said, many injuries which may not be revealed by normal X-rays. But as I told you, I prefer to do traction views and or a proper reduction in the ER, and then send them for either CT, or if not very affording, then you may do it as well without a CT. But CT, the traction view gives you a lot of information in case you are not able to afford or get a CT scan. So ultimately, what you need to understand, as I told you, is assess the involvement of dorsal or volar rim. Look for dye punch fragments, dye punch lesions, particularly in the lunate fossa, because that is the central column where the whole corpus is sort of loading. So you need to restore that, understand that configuration of the dye punch lesion, and see the amount of shortening, and see also the medial column, which is the ulnar, whether there are any fragments when there are fractures in the ulna, or there is any DRUJ involvement. So the medial column also has to be inserted. So post reduction, if there is any radial shortening more than 3 millimeters, dorsal tilt more than 10 degrees, or a step off in the articular fragments more than 2 millimeters, they qualify for a surgical fixation. There are so many classifications, as Dr. Sanjay also said. Classifications don't bother you if you're treating these fractures very regularly. They are good for audit, and they are good for compare your results. As far as management is concerned, it is your own understanding of these fractures and your own knowledge of dealing with these fractures what guides you as far as treatment is concerned. The column concept is a recent concept. As I told you, there's a lot of information coming for radial and distal radius fractures. So this concept is a concept based on 3 columns, where you have a radial column, the intermediate column, or the lunate, the area which I told you is the keystone for this fracture, keystone for distal radius. So restoration of all these 3 columns, particularly the intermediate column, becomes the cornerstone of your fixation, and becomes ensures your good result if you restore these columns. So as I told you, classifications may not help you greatly in fixations if you know them. What is important is to define the fracture personalities. You have to understand the basic configuration of the fracture to get whether to manage it. Your own experience as well as your own learning curve will make you decide how to fix these fractures. So what it needs is to understand the configuration, as you see these intraarticular fragments. There is a lot of literature available on the management of these fractures. The British Society of Surgery, they have said best practice is that below 50 and above 65, under the age of 50 years and up to 65 years, any method may work. Below 50, any method you may do a close reduction, or you may do an external fixator, although external fixators have become little in the background, while in my post-graduation, external fixator became the most important mode of treatment in such comminuted fractures. It was working in a process on a technique of ligamentotaxis, but then over a period of time, it was realized that ligamentotaxis may not work in such fractures. It is the fragment position and fragment configuration which is important in restoring these in the distal radius. So above 65 years, the best practice is that does not provide it does not operative intervention does not provide a superior outcome as compared to non-operative treatment. So and as far as open reduction and fixation is now accepted as a most important mode of management of these fractures for its better early functional outcomes and lower risk of complications as compared to external fixation or even close reduction in intraarticular fractures. As I told you, we are in exciting times. We have lots of implants available. If you just Google distal radius plating, you can see almost 5 lakh results in 0.53 seconds. That's what I was trying to look. So it is, there's flood of information available and flood of techniques and understandings available while seeing distal radius fracture. So we are in a best of the times to deal with these fractures as our understanding is improving. I'll be talking more about volar plating because that is the main stay of present-day distal radius fractures. Although you have dorsal approach also where you need to fix certain particular fractures, but we'll be talking more about volar plating. So volar plating provides stability in osteoporotic bone by buttressing the subchondral bone. It is a simple surgical, very easy. It is just you just cut the skin and you are directly on the muscle and then you are on the bone. So it's a very simple surgical approach as compared to dorsal approach where there is a lot of tendons and a lot of irregular surface of the bone which prevents you from plating the surface. And reduction usually easy in most of the non-comminuted fractures except in very few comminuted fractures where you have to restore the lunate fossa. And it can be useful in almost most of the fractures. So what is important in doing a volar plating is that you need to understand the volar anatomy. So the most important line is the watershed line, what you can see here. That is the surface proximal distal to which the wrist capsule starts, and you cannot go into the wrist capsule because that will lead to the weakening on the side, capsular side, and then ultimately may need to carpal subluxation. So you should be on the proximal to the volar watershed line. And the pronator quadratus line, what is called as, it is the zone between the distal border of the pronator quadratus and there's a fibrous transition zone up to the capsule, which is, it is a immobile zone of the capsule or the fibrous tissue, which can be utilized for suturing the pronator quadratus. So you should understand this zone very nicely if you want to resuture the pronator quadratus. And then there are the radial tuberosity and the via volar radial line on which you need not go if you are putting a plate on the proximal humerus. So that is what is the watershed line. So your plate should always, this is the line where the tendons are closest to the bone. So if your plate is volar to this the ridge, then you are probably impinging on the tendons and you may lead to tendon injuries later, which is common with these volar plating if not taken care of. So stay proximal to the watershed line. It is the most prominent ridge there, and that is proximal to that you need to put the plate. Pronator quadratus is a very useful muscle as far as volar approach is concerned. It is a horizontally laid muscle from the ulnar side to the radial side. You need to lift it from the radial side and like a flap. You can use the fibrous transitional, as I told you, transitional fibrous zone, which is a zone which is between the watershed, the capsular, volar capsule and the ligaments, and then the distal border of the pronator quadratus. You can use that, you can incise in that line and use that later as a, otherwise the sutures in the pronator quadratus may cut through. Pronator quadratus suturing may not be most important thing to do, but then it definitely helps in better rehabilitation and prevents your plate to come in contact with the tendons if your plate is little more distal. So you need to cover it up with the pronator quadratus. So as I told you, you need to identify these bony landmarks while doing a volar plating. You have the volar radial tubercle, you have the volar rim lunate tubercle, also called as on the medial side, which is the most prominent part on the volar side. So that area needs to be buttressed well. to have the restoration of the lunate fossa done properly. And besides the distal radioulnar joint, it has a ball and socket configuration, and the pronator quadrator sweeps over that muscle. So the trajectory of your screws, which you will see in the later slides. So now coming to the fixation mechanics, basically the volar cortex becomes an important part in the restoration of this mechanics. Whether you're doing a closed reduction, the continuity and the stability of the volar cortex becomes the keystone on which your reduction rests. So if your volar cortex is restored very nicely, even in your post-reduction x-rays, as you can see here, there, or in a fixation, if the volar cortex is restored very nicely and buttressed very nicely, probably your fixation is going to last. That is the one part. So volar cortex integrity, then the other thing about the distal radius is the area, subchondral bone is the most thick bone there, and it forms the it provides the stability of your screws. So your screws need to be juxta-articular. So in this subchondral area, if they are little more proximal, they may lose their hold on the bone and probably lead to collapse. So that is very important if you need to put your screws in this subchondral area. And if you can see this area here, this is the thick area, that is the actual stability provider of the carpus. So the rest of the area on the dorsal side, it is a soft area. It is not so thickened. So neither it provides stability to your screws, nor it provides stability to your plate. So putting the screws in that area does not provide any better fixation. So your screws should be subchondral in this area, which is the area extending from these two areas that provides the stability to the screws. So what we prefer to use is variable angle plate, although you have so many other plates, because they give you the modularity, they give you the ability to direct your screws if you're not exactly subchondral, or if you're not exactly able to get your screw into the styloid process here, then that gives you almost 30 degrees of variability. So preferably you should use variable angle plates unless it is it's not an intra-articular fracture, where it is more in the metaphyseal fracture, then you may use a simpler plate in such situations. So what is more, another important maneuver is that volar to carpal translation maneuver. Once you get a reduction, you see, once you have opened the fracture, you have seen the reduction on under the C-arm, then you put the proximal screw, which is a screw in the sliding hole, so that you can move your plate position. As I told you, your screw trajectory should be somewhere in the subchondral area, so that you get a good hold of the subchondral bone. So you put your screws in that area. So you have to slide your plate. So once that is done, your plate is flush with the proximal cortex. Then you need to get the distal cortex into the position. So that translation, either you put a sort of, as I told you, MG roll under the dorsum of the wrist, or you can ask your assistant to lift the wrist up and sort of get it close to the plate, so that the volar angulation and the volar cortex integrity is restored. So that you have to maintain till you put either K-wires or at least a couple of screws there, so that the position is maintained. Otherwise, you might fix that in dorsal tilt. So ensure that you get a good lateral view as well as a good support from the dorsal side of the wrist. As you can see the finger here, it is pressing the proximal cortex and below the sliding hole, as well as pushing dorsally. The other finger is pulling the wrist up. This maneuver is very important to restore, and you have to hold it till you put the screws in position. So as I told you, the bicortical purchase here, you can see the part dorsal to the cartilage is a very thin bone, and it doesn't provide any stability to the screws. So putting your screws as a bicortical purchase doesn't give any advantage. In fact, as you know, the architecture of the dorsal surface, it is the Lister tubercle is the highest point. So on your lateral view, you may see screws still inside, but actually you are jutting out through different areas and then impinging on the tendon. So it's a very common complication of this volar approach if your screws are jutting out. So if your screw is touching the dorsal cortex, that means they are out. So you should be almost, what you measure as a length of 100%, you should use almost 75% of the length. You can see in these slides, you can see most of, on a lateral view, you may see them all inside, but actually they are all, most of them will be out and impinging on very important tendons. on the dorsal side and leading to later complications. So avoid going fully to the dorsal cortex here, put them short, and it has been very clearly proved in different papers that 75% length gives you as much stability as 100% length as far as stability is concerned. But if you put it right up to the cortex, you are impinging on the tendons most of the times. As I told you, variable angle plates also gives you the configuration of the screws. It is very important that you put both rows of screws, because one, it gets a good hold on the distal cancellous bone and the subchondral area, and two, the more volar the more proximal your plate is, you have this area of bone which is available for translation. So there may be loss of fixation, and then it may start collapsing. And so similarly, if you go more distal on the volar side, but dorsally your screw is more proximal, again you have an area of bone which is amenable to collapse. So if there is osteoporosis of this area, the whole thing may collapse. So you'll get again a dorsal tilt over a period of time post-operatively. So it is very important that you have a variable angle. You have 2 rows of screws, one going to the dorsal cortex to the tip, and one from the distal to proximal on the volar side. So it gives a good spread, what is called as double tired subchondral support, and it gives you stability. So these fractures are very good fractures. If you have a good hold on the subchondral fractures, you maintain the stability for until the union is there. So good spread and use of double tires, if you have available, gives a good fixation. The other thing is DRUJ. It's very important you restore the medial integrity, medial wall of the lunate fossa. If there is any impinging of the medial subluxation of the proximal fragment or the distal fragment, you may lose the radioulnar joint movement. So your pronation, supination may be painful. Or if your screws are too medial on the one side, you may hit the distal radioulnar joint and cause later pain in the. So it's very important, if you are overflowing on the medial side, you may miss the medial 2 screws, and don't put those 2 screws if you have got good hold on the die punch fragment anyway with your 1 row before that. So just see that you get good views of the DRU joint, so that you are not inside the DRU joint. The other thing is, as I told you, lunate facet buttress is the most important keystone on which the whole carpus rests. So if your lunate fossa is not restored, or its mid-dorsal or volar wall is not restored, probably the fixation may fail. So that is why even if your lunate buttress is missing your plate, your screw is not having good hold, you need to do additional fixation. Either you can take a suture, or you can use a K-wire and then bend it and keep it there, so that it holds together till the union is occurred. So that buttress is very important. Same way on the dorsal side also, if you have missed the screw on the dorsal side, it can lead to pain in supination and pronation. So what generally, if it's a very comminuted fragment, you may just milk your dorsal fragment into position while you are putting the screws, and then hold them. Or you may put you may just open it dorsally, minimally invasive, and put a K-wire there, or even a screw, 2.5 mm screw there. It's very important that that is held together if it is part of the joint. So restore that dorsal and volar die punch is very important. So coming towards the end, I think complications, as I told you, tendon injuries are very common. If you're not understood the bony landmarks, if you are going towards the watershed line, you might, your volar, the plate should not be volar to the volar, this prominence, and it should not be distal to your watershed line. So tendon injuries are very common. We have seen EPL injuries in many of distal radius fractures if your screws are abutting out. And intraarticular screws, that's why you take a good lateral view, good facet view on the table to see that they are not inside. And loss of fixation, if your screw spread or double tired spread is not there, you might lead. And then DRUJ and DRUJ related complications are very common. So towards the end, I will just say that, as I told you, the dorsal see to it that this lunate rims are restore very nicely. They are stable, and because that is what holds the carpus. No need to go bicortical unless you need to put your screws on the dorsal rim fracture. Then you may do a minimally open their incision, either let the screw capture the fragment, or you can put an additional K-wire there. But don't let it go blind, because you can hit the tendon and cause an injury. And radial plate, if your radial styloid is flying, it is not getting into you may just again open it and put additional K-wire. There's no harm in putting additional K-wires, because it's a very cancellous area and union is very quick. So if you get a good restoration of the architecture, you will probably get a good result also. And volar, you can use, as I told you, you can use fracture specific fixations. Use variable angle plates so that you can capture all the fragments in intra-articular fractures. That's all. Thank you very much.
Thank you very much, Dr. Thar. Now we'll start with the question answer sessions. I can see Dr. Sanjay Agarwala from Hindija Hospital Head. He has also joined. So I welcome Dr. Sanjay Agarwala sir also. So I welcome.
Thank you for the introduction. I think both were excellent presentations, and I really have no questions. I'm left spellbound.
Thank you, Dr.
Agarwala. We'll start with question answer sessions. So delegates can ask their questions over the chat window. So I'll message them to Dr. Sanjay Desai and Dr. Sanjay Dhar. So I have received one question for Dr. Sanjay Desai, that how to differentiate in between the indications, when to use plate, nail, and when to use the innovative this implant which you have to.
So when you have a relatively young patient, then the first objective is we want to preserve the head. So you have, to me, anybody below 70, I want to preserve the head if possible. So that's point number one. Now, once you decide to preserve the head, you have a choice between all the various forms of internal fixation. And when you have a 3-4 part fracture, my first choice is this intramedullary device, which I talked about. However, in 2-part fracture, which are displaced, and the patient is relatively young, then you can use a plate. I don't think it is absolutely essential to use the intramedullary device. You can use a plate if that's what you're comfortable with. I would often do a percutaneous wiring for 2-part fractures in the elderly, say 65, 70, or even above 70. If it's a 2-part fracture and I want to preserve the head, then percutaneous wiring is my indication for the elderly or osteoporotic patients. But 3- and 4-part displaced below 70, my choice is just Unic.
Thank you very much.
I have a question for Dr. Sanjay.
Yes,
Desai.
sir, please go ahead.
Once again, thank you, Dr. Desai, for your presentation. In fact, I have been learning. I have done a couple of cases with just Unic. My worry is always, as you said, avascular necrosis. So, although we restore the medial border, and try to avoid medial soft tissue injuries, but how do you ensure that is there any trick where you ensure that you don't over distract, or you don't, what is your experience of 30 cases, that what you can teach people like me who are just into it and are fascinated with this implant?
So first of all, the incidence of avascular necrosis primarily is decided by the initial insult or trauma. All the plates that we have are likely to further add to the stripping of the periosteum. Yeah. And unlike the plates, the intramedullary device is intraosseous. So the stripping of periosteum that you do for plating is not required. So in this device, the potential destruction of blood supply is even lesser. And in my paper that is published, there was no increased incidence of avascular necrosis with this device as compared to other forms of fixation. So this device does not contribute more to avascular necrosis.
what I mean to say is that like you have a head which is totally separate from the soft tissues around it. It means to ensure the staple has the central position, you need to do certain manipulations. You in fact get tempted to take it out and put the staple on that. But then how do you ensure that you're not causing more damage? Is there any thing you need to be worried about, that you should not touch this, the medial sleeve or whatever? I'm talking of the head fragment.
Yeah, like I said, Dr. Dar, that in this fixation, you need to do very little stripping, number one. The technique you do is, first, I often do this through the superior approach. So you lateral to the acromion, you split the deltoid.
Okay, yeah.
As soon as you tease the deltoid, you see the tuberosities. You secure the tuberosities without holding them with towel clips. Just pass sutures through the tendon bone junction of the lesser and the greater tuberosity, and you secure the tuberosities. And it also allows you to leverage the tuberosities. Then, once you lift the tuberosities with these stay sutures, your head becomes very easily visible to you. And without messing around too much with sharp instruments, you pass the staple trial. The whole surgery is done under C-arm control. So the C-arm doesn't go back and forth. It remains under the sterile drapes all the time. That is how I do it. The C-arm is positioned once before you start, once you scrub the patient, the C-arm is there and the drapes are over the body and the C-arm. So the C-arm doesn't move at all. And under C-arm control, then you pass the staple trial to size the staple into the raw surface of the head. And like I said, there is no stripping at all. All you have done is held stay sutures in the tuberosity to lift the tuberosities, to make the head more visible and accessible. And the assistant is manipulating the shaft, holding the elbow. So you are practically not touching the shaft, not touching the soft tissues, not touching the periosteum. So therefore, whatever incidence of avascular necrosis is destined, it is because of the primary injury. You are not adding further insult to injury.
No, while putting the staples, you try, as you have, as I have learned it, that it has to be put in the center of the head. So you have to almost find the center of the head, the articular surface. To ensure that it is central, you need to sort of move the head a little bit so that you get a good end-on view of the, or you just do it under the C-arm.
Under C-arm, see, once, I repeat, once you lifted the tuberosity, the shaft, the proximal end of the shaft might come in the way.
Yeah.
That the assistant is manipulating, holding the elbow.
Yeah.
And some Hohmann's retractors if required. And then the staple introducer, which is staple trial.
Yeah.
I'm sure you must have seen that.
Yeah.
It's a rod, a circular thing on a rod. You negotiate it on the raw surface. You don't even have to hold the head. You don't have to touch the head. Just put it in the raw surface. And the diameter of the cut surface of the broken surface of the head is such कि आपका staple center में ही जाएगा और कहीं नहीं जाएगा. अगर वो
I don't know, in my two cases it tended to go a little superiorly.
So now it will go in the raw part. Only thing you have to now struggle and need a little experience is to make sure that the staple is parallel to the cut surface.
Okay.
That is the key. Head ke beech mein hi jayega, but it may not be parallel. And if it is not parallel, then the reduction won't be accurate.
Yeah, it may be sort of, and the neck shaft angle may be changed.
Yeah, so if this is the head, it should be parallel, not like this or like this.
Yeah.
So it will be in the raw surface because it is in front of your eyes. But the C-arm helps you ensure that the angle of inclination of the staple is parallel to the cut surface. And once the staple is accurately fitted, then the reduction is automatically going to be anatomic. And then you distract the shaft such that the tuberosities want to fall in place. The operation becomes so easy.
So does your distraction means what are the points you see? One is the medial border restoration and two is that tuberosity should fall in place. Or one of them
Correct.
is fine.
Now, so tuberosity, remember, in this patient, the tuberosities were in that position for last 50 years.
Yeah.
Which means the tuberosity want to fall back in the same place, provided you reconstruct anatomy. And once you put the staple, you put the stem in the shaft, and you under C-arm, you distract that stem and the shell.
Yeah.
There is a distractor, there is a forceps, a tool to distract it.
And
you see under C-arm, and if you distract enough that the Gothic arch is restored, then the tuberosity will want to fall exactly where it has been sitting for last 50 odd years. And this is the innovation of the old Professor Dorzonian implant. There was no possibility of distracting. Now, why it is important to distract? Because every patient's tuberosity fractures at different levels. So you don't want the tuberosity to be fixed in distraction, neither you want too much of overlap, because the tuberosity will not heal unless you restore anatomy. So under C-arm, you either reduce the distraction or increase the distraction, depending on where the tuberosity has actually fractured in this patient.
So that means the medial, the calcar border, it may be little over distracted, it may not matter if your tuberosities are well in position.
Correct. It works on tension band principle.
Yeah. Thank you.
Yeah.
Thank you very much.
So there is one more question, sir, from Dr. Imami Ansari. It is, I think it is for Dr. Sanjay Dhar. So it is related to TFCC injuries, sir. TFCC injuries. How are they dealt with, and is it important to restore the ulnar styloid? In one of the X-rays, there was a TBW for Dr. Dhar.
Yeah. So the third column, what is the ulnar column, is always important. It is not that you need to ignore that. Just restoring the two radial columns is not the most important thing. So at the end of every fixation, you need to check the distal radio-ulnar joint. So if it is unstable, you see in different positions in pronation, supination, and see if there is instability there and there is an ulnar styloid fracture, you need, that means that is, so you need to fix it. If it is a smaller fragment and it is not causing any problem in the distal radio-ulnar joint stability, then you may as well ignore it. And TFCC means, again, if there is a TFCC injury, as per, it's a big topic, so it's a separate topic, so I didn't include that. So it has to be repaired. So that is, if you have the lateral medial column instability, then you need to restore both.
Okay. Dr. Imam Ansari, does that resolve your query? Dr. Imami Ansari, does this resolve your query?
So at the end of every distal radius fixation, you check your radial-ulnar joint stability. So if there is any problem, you need to look at that, why it is there. So whether it is a TFCC or, in fact, if you're able to guess it preoperatively, then you may as well take an MRI to check that there's a TFCC injury, but then you need to deal with that column also.
Thank you, Dr. Sanjay Dhar. Any other questions from any other delegate? You can unmute and ask the questions directly with Dr. Sanjay Desai and Dr. Sanjay Dhar. Any other questions, sir? So I think, sir, there is no more questions. And now I'll request my trauma head, Mr. Tushar Mehta, to give a thanks to everyone, and we'll end the session then. Tushar, sir. Hello, Tushar, sir. Okay. Hello. Am I audible, sir? Tushar, sir. I think my voice is not reaching to him. So with this, our both presentations has ended. So I thank Dr. Sanjay Desai and Dr. Sanjay for their presentation. I also thank all the delegates who have spared their time to join this webinar. And we also promise that we will continue presenting more and more. We will bring more and more good surgeons from across the country, and this will continue from our side, from Meril side, sir. Thank you very much.
Thank you very much. Thank you very much.
Thank you, Meril team.
Thank you,
thank you, Sanjay Dhar, and thank you all the
Dr.
participants.
Sanjay Desai. Thank you very much, sir.
Enjoy it. Thank you.
Bye-bye.
Thank you, sir.
Jalika, Titali.
An institution dedicated to make life healthy again. We believe in creating a sustainable ecosystem for the world, where knowledge is everything at Meril Academy. We wish to empower doctors and paramedical staff with in-depth and explicit knowledge and skill upgradation. Our collaborative learning model, well-structured and specially designed programs make sure that innovation happens daily at Meril Academy.
This is really, I'm really impressed. This is really top-notch of the educational process. One thing is when you hear something, and second thing when you come and see and feel, meet all these people.
It's a very great place for education. Lectures with live surgery, like academic in USA and Europe. It's very good for education with different tricks in surgery.
Collaborating with the Indonesians associated hip and knee surgery.
People who are pioneer in their respective field from different parts of the world to come under one roof and share knowledge is an excellent approach in carrying this medical education forward.
Academy, structure-wise, infrastructure, arrangement is very good and it's great.
I feel very proud that in India we have such a beautiful center, which is no less, maybe more than any international center.
It's very far away from my beyond.
The teaching is excellent,
and the organization of this course is quite good.
And modern facility for training and education.
I can recommend to my colleagues to come here and to get
And get to, the sky's the limit.
Our vision is to transform patient care through professional education to ensure that more patients live longer and healthier life. We are Meril Academy, and we believe knowledge is future.
Audio Jungle.
Thank you, everyone. We are closing down.